What's going on, brother? Thanks for
Welcome to
having me.
Doc Talk Live. We've had so much technical difficulties the last couple of days. I'm with Scott Sigmund. Scott does a podcast as well called The Ortho Show. And Scott and I tried to do a Doc Talk Live earlier today. I'm sorry you guys missed it because that was probably going to be more interesting than this. I hate trying to recreate what we talked about,
It
but
can't possibly be more interesting.
Scott, tell us a little bit about yourself. You're an orthopedic surgeon, right?
I am the original opioid sparing orthopedic surgeon, healer of knees and shoulders left and right, chief medical officer of OrthoLaser Orthopedic Laser Centers, hashtag follow the fro.
So, okay, before we get to the laser center, I want to tell, our audience that I actually saw you give a lecture in Miami over a year ago at a tennis thing. And I like, are you a tennis player? No. But it is true, Scott, your lecture was amazing. And just please comment about how you're able to do surgery and not use post-operative opioids, OxyContin, oxycodone, Lortab, hydrocodone. You are basically either not using any or in incredibly small amounts of opioids. That seems amazing, though I don't use opioids either, so I know it can be done, but you're doing surgery, I'm not. So um, much, much more invasive, I think, but how do you do that?
Yeah, well, I know you're a believer, Brad, so that's fantastic. We love all of our opioid sparing brothers and sisters across the country that are helping to change the paradigm in post-operative pain management. I want to give a shout out to our good friend Alejandro Badia, who was the one that brought me down to Miami to give that lecture. Who's a dear friend of mine and outstanding orthopedic surgeon in southern Miami, southern Florida. So yeah, what we're doing now is quite remarkably, we're able to take some of the most painful surgeries and be able to take you through those safely and effectively, while really not exposing you to opioids at all. And probably the major success around that is a long-acting anesthetic, which is called Exparel or liposomal bupivacaine. And if we think about anesthetics, they work, they numb up the area. The problem is they only last for a certain amount of time, and then the pain comes back. So with this medication, with the longer acting anesthetic, through the first 2 to 3 days when your pain's the worst, basically you're numbed up. And then if you think, I call it sort of the storm of pain. If you think about the time in which the knife goes through the skin and that immediate moment, how painful that is. And then 3 days later, when things have healed up a little bit, it's just not nearly as painful as it was. So by the time the anesthetic wears off, patients aren't that painful. So some of the most, painful operations like rotator cuff repairs, where there was a 17% incidence of opioid chronic use associated with rotator cuff surgery. Now we're doing that opioid free. ACL surgery in one of the most vulnerable groups in our adolescent athletes who had high addiction rates associated with that and would unfortunately go onto heroin and die. We're doing those opioid free now as well. And
Do
so
you
there's
have are you doing these in outpatient surgery centers or are you mostly in the hospital?
Yeah, we're doing it all outpatient surgery centers. Even the patients in the hospital are getting these techniques now too. So we've shortened length of stay, for example, and that's how now you can get a knee replacement surgery or a hip replacement surgery as an outpatient. You come in the morning,
I
you're
feel like
home.
hospitals are able to get things paid for better than the outpatient center paradigm. So I'm curious about, if you're able to get the Exparel that you mentioned covered by insurance. I think I understand how it saves money and saves cost, but um, if it's not covered by the insurance company, do you run into that where you're at? Is it Massachusetts that you're based?
Yeah, we're just north of Boston.
Yeah.
And so the good news is that Medicare finally recognized that opioid alternatives are worth the money, worth spending the money on the front side because of the extreme cost to society to manage patients that have substance use disorder, for the patients that are going and having, overdosing in the emergency room, and all of the cost that's associated, much less the loss of life. And so Medicare now, there's a J code, and actually you can get paid for Exparel for the milligram dosage that you've used. They pay you by the milligram dose. So you're getting compensated for the use of Exparel outside of the surgical bundle. So especially in that Medicare population, there's really no reason that you can't use it in the ASC. And many of the commercial payers are now also coming that way as well. So we're seeing that out of Cigna, we're seeing it out of Aetna, where they're really applying this. And we anticipate, as Medicare goes, the commercial payers go as well. And I think many ASCs have gotten to the point now where they feel it's a responsibility that they have to be able to care for the patients, and it gets dialed into the cost of the system.
Well, that's a whole doc talk in itself. I want to move on a little bit and talk about what you've been doing since COVID hit. What does an orthopedic surgeon do when he can't do orthopedic surgery, Scott?
Well, first of all, sports medicine orthopedic surgeons clearly were not needed in the midst of the opioid pandemic. We went from this, group of highly sought after doctors. I was engaged. I was going to different places, giving talks, and all of a sudden I'm stuck in the master bedroom closet because I'm not going anywhere because they don't need me. And so
I think you got a Patriots thing behind your shoulder there.
Oh, we got all kinds of good stuff here for sure. But this is where
I'm going to have you show me your shoes in a little bit.
We're going to monetize. I got my wife's Manolo Blahniks behind me. I'm hoping to see if we can't get some commercialization out of that.
What is that? I don't even know what that is.
Oh, you do.
Your wife's what?
Her shoes, her fancy heels. And so, yeah, we'll put them in the background and we'll see if we get some advertising.
Back there,
Lubies with your pink bottoms. You know all about this stuff.
I don't. I know nothing.
Come on, Brad.
I think that would be more interesting. Before we talk about what you do during COVID, we go through your closet and check it all out.
Well, the funny
part, have some Louboutins in there.
Oh, we got all kinds of stuff in here. But the funny part is that I sort of really got known for my time in the closet. It was like, because I started giving all my webinars from in here, and then I took over as the host of the podcast of the Ortho Show. And so it was like and everybody else has got the screensavers behind them. And I'm like,
right.
Screw that. This is a pandemic. I'm in my closet because my kids are downstairs yelling. My dogs are barking.
Do you recognize what's behind me?
That looks like a vertebral something or other. Is that the spinal cord?
Yeah, it's the spinal cord. My fiance painted that recently.
That's very cool. Yeah. I love it.
Spinal cord.
So anywho, we spent a lot of time in the closet, and the closet has been very good to me in the pandemic. So
oh, that's crazy. I love it. So we'll get to what you did during COVID, but what is the Ortho Show? How do people see the Ortho Show?
So basically, it's audio only at this point. We are going to transition into video, but basically, the Ortho Show podcast is on all places that you can subscribe to podcasts. So Spotify, Apple, it's everywhere you want to be. You can also go to www.theorthoshow.com, and all of our episodes are there as well. I took over sort of mid-pandemic. It was an existing podcast, but we got along well. The guys decided to see if the Fro and his magic could add some spice to the show. And we brought in some outstanding orthopedic surgeons from around the world. And we just really talk about, the stories and the important things that these doctors are doing. We try to be educational, instructional, but we also like to have fun. We call it levity and brevity, basically entertaining our consumers as well. We're not sponsored. We're doing this because we love it. And we're really happy to be able to provide this sort of entertainment.
That's awesome. That's awesome. All right. So what else have you been doing besides the Ortho Show? Tell us about what you've been doing about COVID.
So I decided I wanted to cure COVID.
Yeah, that's good.
As an orthopedic surgeon, I decided that I'm going to become the principal investigator of a COVID-19 ARDS randomized pilot trial. Why not?
Back up. Tell our viewers what ARDS is.
Okay, that's adult respiratory distress syndrome. It's also the cytokine storm that's seen in COVID. What happens is we don't die from COVID. We die from our over crazy immune response to the virus that basically sets up this crazy storm of inflammation that floods your lungs. You can't breathe. There's fluid in there. Then you get intubated. And if you get intubated, the mortality rate is exceptionally high.
What does it have to do with Scott Sigmund, follow the Fro?
Exactly. How do we get to putting our laser in the hospital for treating COVID? So I've been using laser, again, the opioid sparing approach of how I practice. It was sort of a natural progression to find alternative treatments for pain. And that alternative treatment was basically this laser that we found that has great basic science and clinical background to show improvement in pain and inflammation, both for acute and chronic pain. So I started using it about 3 years ago. We opened up our own clinic. We're now franchising across the country. But the thing that really sort of became a sort of this beacon of idea for me was that when we were using the laser for acute inflammation for orthopedic conditions like a bad ankle sprain or a knee sprain or fractures or bruising and ecchymosis, or I should say bruising and swelling, the laser like 100% melts acute inflammation away over a very rapid period, unlike anything I had seen previous in clinical practice. So I said, okay, it really works well on acute inflammation in the ankle or the knee or the hip or the shoulder. Why can't it work for COVID, which is basically acute or crazy inflammation gone haywire? And so basically, I went to the hospital. I went to the IRB, which is the Institutional Review Board. So you can't just do a study. You got to go and talk to some smart people, and they think about it. Is it a good idea? Are we going to hurt anybody? That sort of thing. So the IRB looks at me and says, "Well, that's a great idea, Scott, but we don't know really much about lasers, so we're going to need some guidance from the FDA." So I said, "Okay, no problem. I'm going to call the FDA."
Mhm.
And in the crazy world of pandemic, I got a call back 6 hours later.
Wow.
It was really unbelievable.
That's
And then we gave them all the specs of our laser, and over a 6-day window, the FDA got back to us and said, "We understand this is an FDA cleared device for musculoskeletal inflammation, and now it is a non-significant risk device for a pulmonary study for COVID." I took that back to the IRB. They looked at me and said, "Okay, this sounds a little mashugana, but we'll let you do it." And so, sure enough, now I'm thinking to myself, all right, okay, we got the laser, I got the approval. I mean, I know what the dose is for the hip or for the knee. What am I supposed to do for the lungs? And so I got out the Google machine and I just started, plugging in stuff, COVID, laser, etc. And all of a sudden, there's this website called ResearchGate, and it's basically it's like the LinkedIn for research geeks around the world, scientists who are doing projects, etc. And I got in there, and it just so happens that two MD PhDs from Canada had just written a paper on the theory of using laser for COVID.
Oh,
So
that's convenient. That's
unbelievable. This whole
amazing.
story is it's such a weird sort of vibe as to how it all came together. And so I DM'd Soheila McMully, who is now become a dear friend of mine, and she's like, "Yeah, we could do this." And I've been using it on patients with COPD. I've been using it on patients with asthma. We've seen some good results. So I said, "Look, here are the specs of my laser. Can you give me some ideas as to what the dose should be?" 45 minutes later, she calls me back and says, "Here's the dose." I plug it into the laser and the numbers came out right. And I'm like, "Oh my God, this is really cool." And then we brought the laser in, and this is in the midst of the pandemic. It's super bad up here in Boston. The morale is low. Everything is shut down. Only patients in the hospital are COVID patients. We have three, basically. We've gone from one ICU to four ICUs. The morale of the nurses and the doctors is super low because we're really not treating anybody. They're just sort of watching the patients. Unfortunately, many of them were dying. And there was no real active treatment. The malaria drug wasn't really out or working, and then there was remdesivir, which is the antiviral, which we didn't really have either. And so we went ahead and we brought the laser in, and I'll never forget it. So we talked to the first patient. The case report's out. It's now been published in a peer review case report journal, the American Journal of Case Reports. So we're very happy that the first in human patient has had laser for COVID has been peer reviewed and published. So we walk in the room, and he was just a very gentle, kind man. And I looked at him and said, you know, "This has never been done before, but I've got this laser, and theoretically, I think it can help you."
Was he on a ventilator or just oxygen? What was his
He had just rolled out of the ICU. He was on 6 liters of oxygen in the ICU. They brought him down to the floor, monitor floor. He was on 3 liters. He was failing to thrive. He was not able to get out of bed. He was barely eating. He was a sick individual. And basically, he just looked at me and said, "Doc, sure, why not? Let's give this a try." And I always find that profound that somebody's willing to try something that's really never been tried before. And we rolled him over into the prone position, which is how you do the laser. And the laser's about 20 centimeters above the skin. It never touches the patient.
You
And then
don't have any pictures of your
yeah,
machine, do you?
can I share? Can I share my screen here? Yeah, let's see if I can share the screen. Host disabled. You've disabled me, Brad. You
What
need to
did I
let me
do? Seth,
Do that. Seth,
Seth,
where are
help
you,
me,
Seth?
Seth. Help me, Seth.
Come on, let the fro in here, Seth. Let's go.
Let's see. Share screen. That's my screen, right?
Yeah, there's got to be some sort of a thing that you can do while he's doing that. But I can tell you,
Yep. Okay.
we put him in the prone position.
You can do it now.
Oh, he said I can do it now.
Yes,
Okay,
Seth.
let's see.
Seth is
All
somehow
right.
giving you permission.
All right, we're going to share my desktop. Now let me see if I can find what I want to do here. Hold on a second, guys. Okay, here we go.
Are there any questions? I can't see the Facebook page, but are
Guys,
there any
can you see this now? Can we see the video okay?
Can we see this now, Seth?
Are you seeing what I see?
Are we seeing what he's seeing? Is that on the is it live? Okay. I think everybody's seeing it.
Okay,
Yeah.
good. So here we are. Here's the patient. He's in the prone position. You can see the laser here. It's a mobile scanner, so it never touches the patient. It's about 20 centimeters above. And what's cool about this laser, it's a cold laser, it doesn't generate any significant heat. So you don't have to worry about burning the patient or creating blisters or anything along those lines. And what's remarkable, you can't hear the pulse ox in the back, but they actually get better in the midst of the treatment.
Oh my God. So the
They-
pulse ox gets better while
It gets
they're-
better. And now, so some of the critique on our study was, well, the reason it's getting better is because you're in the prone position, but actually, the truth is, you have to be in the prone position for about 5 to 6 hours to start seeing improved oxygenation. So that's really not what was happening. It was really the laser that was working. So we saw his pulse ox go from 92, 93 all the way up to 100, and then it's 14 minutes per lung field. And then he sits back up at the end of his treatment and he looks over at me, and I'll never forget it. It was a very profound moment. And he says, "Hey, doc, I'm feeling better. Is it okay if I order a strawberry milkshake?"
So that was your first patient. How
Yeah.
many have you done since?
So 10 patients were enrolled into the study. It's a pilot study. It's a very small study. We're a community hospital. We didn't really have the structure in place to run a large trial. 5 patients were in the treatment group. 5 patients were in the control group. I can't comment on the outcomes. What I can tell you is that we are in the midst of finishing the manuscript as we speak. We're going to be submitting to the New England Journal of Medicine. That should mean something.
Wow.
So everybody knows
Wow.
that's the #1 journal in the world for, disclosing important information. We actually should have another case report on another very interesting patient that was accepted to another journal. Hopefully that will be published later this week. So the second patient within the study that had results will also be available in publication. So it's real. I am very confident that this is a viable supportive treatment for COVID. But what we need, and anybody out there listening, this is super important. We need an academic center to pick up the baton and run with this. And that is really what our message is. Let's get a larger randomized controlled trial here so we can further prove the science of this. Wouldn't it be great? We're all worried about COVID. Do I get the vaccine? Do I not get the vaccine? What happens if I get sick? What if we actually have a viable treatment with the use of light by plugging it into the wall with no medicines and no risk of complication? It's pretty.
Well, who sells the laser? Who's the laser manufacturer?
So the laser manufacturer is Assa Laser, which is located in Vicenza, Italy, which is just outside of Venice. The laser distributor in North America is Cutting Edge Laser. And then the name of the laser is actually called the MLS laser. It's the multi-wave locked system. And the reason that this laser is so unique is, number one, it's a class 4 laser, so it's high powered. Number 2, it has pulsed energy, which prevents the issue for complication, for the issue of blisters, etc. And then the mobile scanner is great in the setting of COVID because you never touch the patient. We still decontaminate when we roll out of the room, but again, nobody's physically touching the patient during the treatment, which is pretty amazing. So these lasers, are purposed for acute and chronic inflammation, FDA cleared for that purpose. In order to get in an on-label use, obviously, we're going to have to get some studies done to prove that to the FDA. Although I would argue and say at this point right now, if, like, for example, if my mother came down with COVID, I'd bring the laser home and I would use it on her. You can, as a physician, as you know, use anything that's off-label as long as you have individual consent with that patient to go over the risks,
Sure.
benefits, and alternatives of the use of it. So we have the ability to do so, but what we can't do is just use it outright and say that it works without having some sort of proof.
Right. But it would seem to me that the people who make the laser would be strongly incentivized to set up a research study, um, because what you're saying is obviously quite important. There is no good treatment. It always turns out to be a dollars and cents type of thing as far as, why somebody would do a research study on something.
Yeah, I mean, I would tell you this. I mean, through the laser world is sort of this underworld. Everybody knows each other everywhere around the world. Laser's actually fairly well recognized in most other countries. For whatever reason, in the U.S., the number one utilization of laser is veterinarians, believe it or not. And they about 60% of the veterinarians across the country use laser routinely, both for post-surgical pain as well as for chronic inflammatory conditions. And let's face it, dogs and cats don't have a job. They don't have secondary gain. If they walk in with a limp and they get lasered and they walk out without a limp, then we're pretty, confident that that laser worked. But so, for example, we're aware of a study both in Russia as well as in Brazil, which is a large scale randomized controlled trial that sounds to have been successful. And I think that will be something published from those two institutions hopefully soon. And rising tide for all boats. We want laser to become, a very well recognized form of treatment for sure.
Well, if you can get in the New England Journal of Medicine, that would be huge. I bet that would um, motivate a lot of university centers to pick up the baton on
And
that,
that's,
right?
really the issue now, in the United States, people are just not aware of it as a treatment option. So for them to say, oh yeah, we're just going to go ahead and do this, it doesn't click. But, I think that, without a doubt, these lasers are available. And, one of the other issues that's going to be interesting is that, laser does not have a CPT code. For those who are listening, that's a code that allows an insurance company to pay doctors or hospitals for treatment. It's so, for example, if you're getting your eyeball, you're getting a cataract out, it's got a CPT code. If you're getting, a herniated disc removed, it's got a CPT code, etc. But there's no CPT code for laser. So if it turns out that this is a viable treatment option, there's not going to be a revenue generator for the hospital by using this. But what it will do, obviously, is reduce the cost and expense of running 4 ICUs for the second wave of COVID that may be coming in the fall, and all, the
So
treatment of
when
death,
you
etc.
when you were previously using your laser in orthopedics, were patients just paying cash?
Yes, it is a patient pay model. There's no insurance that pays for it whatsoever. But, we said it, people that are in pain as a general rule are willing to do what they can to get out of pain, especially. And so most of the thing, go ahead.
How does this laser different from, you mentioned like skin, or I didn't you we've done lasers on skin and things like that for wrinkles. How is your laser different?
So laser, there's a few factors that are important about laser. Number one is the power. How powerful is it? How much energy can it generate? And remember, it's the photons or the light energy, the particles that go in. The next most important thing is wavelength. And the wavelength is what determines the depth of the penetration. So for skin lesions, etc., you want to have a laser that's penetrating no more than, 2 or 3 millimeters into the tissue. So you have to have the focal length as well as the wavelength of light energy to go that far. Orthopedics, we go in deep. Our things are 4 or 5, 6, 7 centimeters deep. So you need to have a wavelength that will allow that to happen. And that's near infrared light. The two wavelengths that we use are 808 and 905, and that allows it to penetrate. The penetration of the wavelengths is dependent on water, skin pigment, and hemoglobin. And there's that sort of perfect area in the 800s to early 900s that allows that penetration. And then the final thing, which is super unique about the MLS laser, which we use, is basically the pulsed nature of the laser. Most other lasers can generate heat. And so it's handheld, and the hand wand needs to be moved around so that you're not creating skin necrosis or blisters, etc. But because ours is pulsed 1,500 times, that's not a concern.
Gotcha. Gotcha. So can we see the closet now?
Yeah, man, it's right behind me.
Seth, do you know if there's any questions on Facebook? Because
Yeah.
usually I can see on Facebook, but I can't do that with Zoom apparently.
Yeah, Mr. Beckman says he found out that his brother-in-law is a hospital with COVID. Any chance he could be a trial subject?
But he's in Birmingham, so we've got a patient already for you in Birmingham that wants to try the laser.
It's funny. We've published on LinkedIn, on Facebook, on Instagram, and I would say 99 out of 100 comments have been overwhelmingly positive. Looking for some sort of a treatment option that's out there. But there's always the naysayers. That the Earth is still flat, and you've only done one patient or two patients. But science has to start somewhere. You have to have an idea. You got to give it a try. And the reason in which we've done this publication, and the reason I'm so happy, Brad, that you got me on here, is that we really want to be able to share this information so that we can generate the larger trial to make it happen, so that Mr. Beckman in Alabama can basically get his treatment as well. And that's what we're trying to achieve.
Any more questions, Seth?
I think Ed Beckman also wants to know where Sigmund is from. He tuned in late.
Tell us your location again, your about your practice, how people find you, Scott.
So my APGARs were 9 and 9. I was really good when I came out.
You are Michigan.
Exactly.
Even people in Alabama know that word.
Exactly. So I am an orthopedic surgeon. I practice out of Orthopedic Surgical Associates, which is in North Chelmsford, Massachusetts. We're approximately 25 miles north of Boston. I've been in practice up here for 25 years. You can find me in a lot of places, scottasigmundmd.com. You can find me on ortholaserwithaz.com. You can find me on the orthoshow.com. We've got a lot of stuff going on and a lot of places that you can find the fro. That's for sure.
Find the fro. And I'll get Christy to hashtag all that nonsense.
That's great.
Sorry, you're probably more well versed at this.
You got
social
Seth.
Media,
you got Seth and Christy. You're okay.
Exactly. Any more questions out there?
Yeah, that's it for now.
All right, that's it for now. Good. So Scott, just a few more housekeeping things. Number one, we're going to need a follow up. On what you call photobiomodulation. So we're going to want to know how things turn out a month, 2 months from now.
That'd be great.
If you ever wanted, so Doc Talk Live, let me just tell you, Scott, I started this project a couple years ago. It's not sponsored. It's just something I enjoy doing. I get to meet people like you. It's not about me at all. So if you ever want to take over the show and do what we call a Doc Talk takeover, that would be awesome. Like you go in with your phone, what Christy will show you how to get the credentials, but then you just go in and do a live Doc Talk with one of your patients. That would be awesome. We'd love to have you
that'd be great.
As a guest host. I know you're really not doing orthopedic surgery right now up there, are you? Are you guys back operating?
Yeah, no, we're full tilt. I mean, I'm in the office near 100%. So yeah, we're. But what we could do would be kind of fun if the second case report gets published, which I think it will. The patient has very graciously agreed to be involved in interview process and all of that. So we could potentially bring the patient on, and she could tell her side of the story.
That'd be fun. And also, I'd love to see you do a treatment where the patient's lying down or whatever. But
sure.
Anyway, so think about that. Doc Talk Live takeovers, definite. We'll need some follow up on this subject. And that's all I got for you now, Scott.
That's all good, man. It's all great. That was awesome. I'm going to go eat some sushi with my boys. Peace out, everybody. Have a great night.
Matzo ball soup, huh?
Not tonight. Not tonight. Be
Thanks.
good.
See you later.
See you later.
All right, I'm going to hit end. End meeting.